Block Simulation 6. Same engine, new questions. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. Through which pathway is this reflex mediated? A 55-year-old man undergoes carotid sinus massage during evaluation of palpitations. Pressure on the carotid sinus produces a transient drop in heart rate and blood pressure. Read the command pathway of this reflex. Carotid sinus massage lowering heart rate and blood pressure. The baroreceptor reflex. The carotid sinus is a baroreceptor, a stretch receptor in the wall of the internal carotid artery. When external pressure or rising blood pressure stretches it, the receptor fires more. The afferent signal travels via the glossopharyngeal nerve, cranial nerve, IX, to the solitary nucleus in the medulla. The medulla responds by INC-ERE, parasympathetic vagal output, and DEC-ERE sympathetic tone, which slows the heart rate and lowers blood pressure. Carotid massage artificially stretches the sinus, mimicking high pressure, so the reflex drops heart rate. The correct answer is C. 2 anatomic pairings to lock in. The carotid sinus sends baroreceptor signals via CNX, glossopharyngeal, while the carotid body chemoreceptors and the aortic arch baroreceptors signal via CNX vagus. Increased carotid sinus firing means slower heart. The body interprets it as high pressure. This reflex is why carotid massage can break certain tachycardias. Why is the erythropoietin level low in this patient? A 60-year-old man presents with headache, dizziness, and pruritus that is worse after hot showers. Exam, facial plethora, ruddy complexion, and splenomegaly. Labs, HGB 19.5, GB-atyl, hematocrit 58%, platelets and WBC mildly elevated. Erythropoietin level is LOW. A J2V617F mutation is detected. Read the command. Why is EPO low? Elevated hemoglobin and hematocrit, aquagenic pruritus, plethora, splenomegaly. LOW, J82, mutation, polycythemia vera. Polycythemia vera is a myeloproliferative neoplasm driven by the JAK2V617F mutation. JAK2 is the signaling kinase downstream of the erythropoietin receptor. The mutation makes it constitutively active. The marrow behaves as if EPO is constantly present, overproducing red cells, and often platelets and granulocytes are independent of erythropoietin. Because the red cell mass is high, the normal feedback loop senses the elevated oxygen carrying capacity and suppresses renal EPO production. So EPO is low. The proliferation is autonomous, not EPO driven. The correct answer is D. This low EPO is the key discriminator. In secondary polycythemia from chronic hypoxia or an EPO secreting tumor, choices B and E, EPO would be HIH-CoA. That is what is driving the red cells. In polycythemia vera, the drive is intrinsic JAK signaling, so EPO is appropriately low. Aquagenic pruritus and plethora are classic clues. Treat with phlebotomy and hydroxyurea. A deficiency of which enzyme is most likely responsible? A 2-week-old infant presents with poor feeding, vomiting, jaundice, hepatomegaly, and lethargy. The mother notes the symptoms began after breastfeeding started. Exam shows bilateral cataracts. Urine tests positive for a reducing substance but negative for glucose on dipstick. Sepsis with E. coli is suspected. Read the command. Which enzyme? Infant after milk feeds. Vomiting, jaundice, hepatomegaly, cataracts, reducing substance in urine, E. coli sepsis risk. Classic galactosemia. Classic galactosemia is a deficiency of galactose-1-phosphate uridyltransferase, GALT. Lactose in milk is broken into glucose and galactose. Without GALT, galactose-1-phosphate accumulates, which is toxic to the liver, brain, and kidneys, causing the vomiting, jaundice, hepatomegaly, and failure to thrive that begin once milk feeding starts. Galactose is also shunted by aldose reductase into galactitol, which accumulates in the lens and causes the infantile cataracts. These infants are at high risk for E. coli sepsis, Treatment is removing galactose and lactose from the diet. The correct answer is D. Distinguished from galactokinase deficiency, choice B, a milder disease whose main finding is isolated cataracts. Without the liver damage and sepsis risk, because the toxic galactose 1-phosphate does not accumulate. A severe multi-organ picture plus E. coli, sepsis points to classic galactosemia and GALT. Which tracts are responsible for the left-sided deficits? A 42-year-old man is stabbed in the back, injuring the right half of the spinal cord at T10. On exam below the lesion, he has right-sided loss of motor function and loss of vibration and proprioception, with left-sided loss of pain and temperature. Read the command. Which tract causes the left-sided deficits? Cord hemisection, brown, sequard, with contralateral pain and temperature loss. The spinothalamic tract. This is Brown-Séquard syndrome, hemisection of the spinal cord. The trick is knowing where each tract crosses. The spinothalamic tract carries pain and temperature. It crosses almost immediately, within 1 or 2 levels of entering the cord. So by the time it is ascending on the right side, it is already carrying sensation from the LEF side of the body. Damaging the right spinothalamic tract therefore causes loss of pain and temperature on the contralateral LEF side, beginning a couple of levels below the lesion. The correct answer is B. Contrast the two sensory systems. The dorsal columns carry vibration and proprioception and ascend UNC ROST, crossing only in the medulla. So a right cord lesion causes ipsilateral right loss of vibration and proprioception. The corticospinal tract also already crossed in the medulla, so a right cord lesion causes ipsilateral right weakness. Pain and temperature are the exception, crossed at the cord, so the deficit is contralateral. Which eponymous sign reflects the migratory thrombophlebitis seen here? A 67-year-old man presents with painless jaundice, weight loss, and dark urine over 6 weeks. Exam reveals a palpable, non-tender, distended gallbladder. He also reports migratory superficial venous thrombosis in different sites over the past months. Labs, direct bilirubin elevated, CA19-9 markedly elevated, CA19-9 markedly elevated. CT shows a mass in the head of the pancreas. Read the command. Which sign reflects the migratory thrombophlebitis? Painless jaundice, palpable non-tender gallbladder, weight loss, high CA19-9, pancreatic head mass, migratory venous thrombosis, pancreatic adenocarcinoma with Trousseau syndrome. The migratory superficial thrombophlebitis, clots appearing and resolving in different superficial veins over time, is Trousseau syndrome. It is a perineoplastic hypercoagulable state classically associated with pancreatic adenocarcinoma, though it occurs with other visceral cancers too. The tumor releases procoagulant factors including tissue factor and mucins that activate the clotting cascade, producing recurrent migratory clots. This is the answer to the specific question. The correct answer is E. The other eponyms are also pancreatic cancer associated, but describe different findings. Courvoisier's sign is the palpable, non-tender, and large gallbladder with painless jaundice. Virchow node is a left supraclavicular node. Both appear in this patient, but the specific sign for the migratory clots is Trousseau. CA19-9 is the tumor marker for pancreatic cancer. What is the primary function of this arrangement? A physiologist studies the nephron's ability to concentrate urine. She notes that the descending limb of the loop of Henle is permeable to water but not solute, while the thick ascending limb actively pumps out sodium, potassium, and chloride but is impermeable to water. Read the command. Primary function of this arrangement. Descending limb permeable to water. Thick ascending limb pumping the AKL but impermeable to water. Countercurrent multiplication. This arrangement is the countercurrent multiplier, and its purpose is to build a hyperosmotic medullary interstitial gradient that lets the kidney concentrate urine. The thick ascending limb actively pumps sodium, potassium, and chloride out via the NAK2-Kel cotransporter, the target of loop diuretics, but is impermeable to water. This dilutes the tubular fluid and loads the medullary interstitium with solute, making it hyperosmotic, up to 1,200 milliosmoles deep in the medulla. The descending limb, permeable to water but not solute, then loses water into that hyperosmotic interstitium, concentrating the fluid as it descends. Demultiplication comes from the countercurrent flow, amplifying a small gradient along the length of the loop. The correct answer is E. That medullary gradient is what ADH later exploits. ADH inserts aquaporins in the collecting duct, and water flows down the gradient into the hyperosmotic medulla, producing concentrated urine. Loop diuretics block the NK2Cl pump, collapse the gradient, and impair concentrating ability. The whole point of the loop architecture is this concentrating gradient. What is the mechanism of action of this drug class? A 60-year-old man with coronary artery disease is started on atorvastatin. 6 weeks later, his LDL is substantially reduced, but he reports diffuse muscle aches. Creatine kinase is elevated. Read the command mechanism of action. Atorvastatin lowering LDL with myalgia, an elevated CK, statin, HMG, CoA reductase inhibitor. Statins inhibit HMG-CoA reductase, the rate-limiting enzyme of the cholesterol synthesis pathway in the liver. It converts HMG-CoA to mevalonate. By blocking endogenous cholesterol production, statins reduce intracellular cholesterol, which prompts hepatocytes to upregulate LDL receptors on their surface. More LDL receptors pull more LDL out of the blood, lowering serum LDL, the most effective LDL-lowering class. The classic adverse effects are myopathy, ranging from myalgia with elevated CK to rare rhabdomyolysis and hepatotoxicity. The correct answer is B. Match the other lipid drugs to their targets. Ezetimibe blocks intestinal cholesterol absorption. Bile acid resins like cholestyramine sequester. Bile acids, fibrates activate PPAR alpha and best lower triglycerides, and the MAB agents inhibit PCSK9. The myalgia with elevated CK is the signature statin toxicity. Risk rises when combined with fibrates. Which statement about this malignancy is correct? A 4-year-old boy presents with fatigue, easy bruising, bone pain, and fever. Exam, pallor, petechiae, hepatosplenomegaly, and lymphadenopathy. CBC, HEB 7.0, platelets 22,000, WBC 32,000 with numerous lymphoblasts. Bone marrow is hypercellular with numerous lymphoblasts that are TDT positive and CDT positive and CDT positive. Coloposas that are TDT positive, cytogenetics show 1221. Read the command. Which statement is correct? Child, lasts, pancytopenia, hepatosplenomegaly, TDT positive, CDT positive, colopositive, 12, 21, acute lymphoblastic leukemia. This is acute lymphoblastic leukemia, the most common cancer of childhood, peaking around age 2 to 5. The blasts are lymphoid, TT positive, a marker of immature pre-B and pre-T lymphoblasts, and in B cell, ALL, also CD10, the caller antigen, positive. The marrow is packed with over 20% blasts, crowding out normal cells and causing anemia, thrombocytopenia, bone pain, and infections. The cytogenetics matter for prognosis. The T12-21 translocation, common in children, carries a good prognosis, whereas the Philadelphia T9, 22, and ALL is poor. The correct answer is A. 2 more high yield points. TDT positivity indicates LYM-oid, not myeloid, origin, so choice C is wrong. An ALL characteristically spreads to sanctuary sites, the CNS and the testes, which is why treatment includes intrathecal chemotherapy and CNS prophylaxis, so choice E is wrong. Overall childhood ALL is highly curable. A deficiency in which part of the immune system best explains his recurrent infections with this organism. A 19-year-old college freshman in a dormitory presents with fever, severe headache, neck stiffness, and a rapidly spreading petechial rash. He becomes hypotensive. CSF shows neutrophilic pleocytosis, low glucose, and gram-negative diplococcy. He has a history of recurrent Neisseria infections. Read the command. Which immune deficiency explains recurrent Neisseria infections? Meningococcal meningitis with petechial rash, gram-negative diplococci, recurrent Neisseria, terminal complement deficiency. Neisseria meningitis is the organism, a gram-negative diplococcus causing meningococcemia with the characteristic rapidly spreading petechial or purpuric rash and septic shock. The key to the question is the recurrent Neisseria infections. Defending against Neisseria species depends heavily on the membrane attack complex, the terminal complement components C5 through C9, which punches holes directly in the bacterial membrane. Patients deficient in any of these terminal components or in the regulatory protein suffer recurrent disseminated Neisseria infections, both meningococcal and gonococcal. The correct answer is A. This is a classic immunology pairing. Recurrent Neisseria equals terminal complement or MAC deficiency. Choice E, NADPH oxidase, gives chronic granulomatous disease with catalase-positive organisms, a different pattern. The recurrent Neisseria specifically signals a terminal complement defect. Patients should receive meningococcal vaccination. Which cell secretes this hormone, and what is the principal stimulus? After a fatty meal, a hormone is released from the duodenal mucosa that causes gallbladder contraction, relaxation of the sphincter of Oddi, secretion of pancreatic enzymes, and slow gastric emptying. Read the command. Which cell and stimulus? Hormone after fatty meal causing gallbladder contraction, sphincter of Oddi relaxation, pancreatic enzymes, slow gastric emptying, cholecystokinin from eye cells. This hormone is cholecystokinin, CCK, secreted by the eye cells of the duodenal and jejunal mucosa. Its principal stimuli are fatty acids and amino acids in the small bowel. CCK does exactly what the question lists. It contracts the gallbladder to release stored bile, relaxes the sphincter of Oddi, so bile and pancreatic juice into the duodenum, stimulates pancreatic acinar cells to release digestive enzymes, and slows gastric emptying to give time for digestion. The name itself, cholecystokinin, means move the gallbladder. The correct answer is E. Keep the GI hormones and their cells straight. Gastrin from G cells, stimulated by distension and peptides, raises acid. Secretin from S cells, stimulated by acid, raises pancreatic bicarbonate. Somatostatin from D cells, inhibitory, and CCK from I cells, inhibitory, and protein, gallbladder, and pancreatic enzymes. The fatty meal gallbladder picture is CCK from I cells. What is the underlying defect? A 20-year-old man presents with tremor, dysarthria, clumsiness, and recent personality changes and declining school performance. Exam shows brownish rings at the corneal limbus on slit lamp examination. Labs, low serum ceruloplasmin, elevated 24-hour urinary copper, and elevated hepatic transaminases. Read the command. Underlying defect: young patient, movement disorder, plus psychiatric changes, plus liver disease, Kaiser-Fleischer rings, low ceruloplasmin, high urinary copper, Wilson disease. Wilson disease. Hepatolenticular degeneration is caused by a mutation in the ATP7B gene, which encodes a copper-transporting ATPase in hepatocytes. This protein normally does two jobs. It loads copper onto ceruloplasmin for the blood, and it excretes excess copper into the bile. When it is defective, copper cannot be excreted and accumulates, first in the liver, causing hepatitis and cirrhosis, then spilling into the blood and depositing in the basal ganglia, causing the tremor, dysarthria, and Parkinsonism, the cornea, Kaiser-Fleischer rings, and the kidneys. Serum ceruloplasmin is low because the defective transporter cannot load copper onto it. The correct answer is C. The triad to recognize is liver disease plus neuropsychiatric symptoms, plus Kaiser-Fleischer rings in a young patient with low ceruloplasmin and high urinary copper. Contrast with hemochromatosis, choice B, which is iron, not copper. Treat Wilson disease with copper chelators like penicillamine or trientine and zinc. Where is the lesion, and which structures are involved? A 68-year-old man presents with sudden onset double vision and weakness. Exam. The right eye is deviated down and out with a dilated, non-reactive right pupil and ptosis. He also has weakness of the left arm and leg. Read the command. Where is the lesion and which structures? Right CN3 palsy, down and out eye, dilated pupil, ptosis plus contralateral left hemiparesis. Weber syndrome, a midbrain stroke. This is Weber syndrome, a medial midbrain stroke, usually from occlusion of paramedian branches of the posterior cerebral artery. Two structures are hit on the same right side. First, the fascicle of cranial nerve 3 as it exits the midbrain. This gives the ipsilateral right oculomotor palsy. The eye is down and out because the unopposed lateral rectus and superior oblique pull it there, plus ptosis and a dilated non-reactive pupil from loss of parasympathetic fibers. Second, the cerebropeduncle, which carries the corticospinal tract. Before it crosses in the medulla, so it produces contralateral left-sided weakness. The correct answer is C. This is a classic crossed brainstem syndrome, an ipsilateral cranial nerve deficit with contralateral body weakness localizes the lesion to the brainstem on the side of the cranial nerve. CN3 plus contralateral hemiparesis equals midbrain, Weber. The cranial nerve tells you the level. The crossed motor findings confirm a brainstem, not the cortical lesion. What is the correct interpretation? A randomized trial compares a new antihypertensive to placebo. The new drug lowers systolic BP by an average of 6 mmHg more than placebo. The reported 95% confidence interval for this difference is 1 to 13 mmHg, and the p-value is 121.9. Read the command, correct interpretation. Mean difference, 6 mmHg, but 95% CI from 1 to 13 includes 0, POD9, not statistically significant. Two pieces of information both point to the same conclusion, and they must agree. First, the 95% confidence interval runs from -1 to 13, yet INS includes 0. When a confidence interval for a difference includes 0, it means no difference is a plausible value, so the result is not statistically significant. Second, the p-value is 0.0 than the conventional threshold of 0.05. Both criteria say the same thing. We fail to reject the null hypothesis. The correct answer is A. A crucial nuance, not statistically significant, does not prove the drug has no effect. Choice D and C are wrong. It means this study lacked the evidence or the power to demonstrate 1. The true effect could still be as large as 13 mmHg. A confidence interval that crosses 0 and a p-value above 0.5 always travel together. Absence of significance is not proof of no effect. A deficiency of which enzyme is most likely? A 15-year-old boy is tall with long, thin extremities, a pectus deformity, and downward subluxation of both lenses, ectopia lentis. He has intellectual disability and a history of a thromboembolic stroke. Urine testing is positive for a sulfur-containing amino acid. Symptoms improve substantially with high-dose vitamin B6. Read the command, which enzyme? Marfanoid habitus, downward lens dislocation, intellectual disability, thrombosis, sulfur amino acid in urine, response to B6, homocystinuria, cystathionine, synthase deficiency. This is homocystinuria, most often from deficiency of cystathionine beta synthase, the enzyme that uses vitamin B6 to convert homocysteine to cystathionine. Homocysteine accumulates and spills into the urine. Excess homocysteine damages the vascular endothelium and collagen, producing the Marfanoid body habitus, lens dislocation, intellectual disability, and, critically, a markedly increased risk of premature thrombosis and stroke. Because the enzyme is B6 dependent, many patients respond dramatically to high-dose vitamin B6 pyridoxine. The correct answer is D. The classic exam discriminator is homocystinuria versus Marfan syndrome because both produce a tall, thin Marfanoid body and lens dislocation. The difference is homocystinuria dislocates the lens downward and adds intellectual disability and thrombosis, while Marfan fibrillin 1 defect dislocates the lens UP ward with normal intellect and aortic risk. the B6 response and thrombosis nail homocystinuria. What is the most likely diagnosis? A 58-year-old man presents with 6 weeks of worsening headaches, a new seizure, and progressive left-sided weakness. MRI shows a large heterogeneous right hemisphere mass with central necrosis and ring enhancement that crosses the corpus callosum in a butterfly pattern. Biopsy shows highly cellular astrocytic tumor with nuclear atypia, microvascular proliferation, and regions of necrosis surrounded by palisading tumor cells. The tumor stains positive for GFAP. Read the command, most likely diagnosis. Adult butterfly lesion crossing the corpus callosum, ring enhancement with central necrosis, pseudopalisading necrosis, microvascular proliferation, GFAP, positive, glioblastoma. Glioblastoma, grade IV astrocytoma, is the most common and most aggressive primary brain tumor in adults. 2 histologic features are essentially diagnostic: microvascular, endothelial, proliferation, and regions of necrosis rimmed by densely packed tumor cells lined up around them, pseudopalisading necrosis. It arises from astrocytes, so it stains positive for GFAP, glial fibrillary acidic protein. On imaging, it classically crosses the corpus callosum to involve both hemispheres in the butterfly pattern with central necrosis and ring enhancement. Prognosis is poor, around 12 to 15 months. The correct answer is B. The combination of pseudopalisading necrosis, microvascular proliferation, GFAP positivity, and the butterfly pattern crossing the midline is specific for glioblastoma. Meningiomas are extraaxial, dural-based, and psammoma-bearing. Oligodendrogliomas show fried egg, cells, and calcification. The necrosis and GFAP astrocytic picture points to glioblastoma. What is the acid-base disturbance and why does it persist? A 34-year-old woman with anorexia nervosa is admitted after weeks of self-induced vomiting. She is volume depleted. ABG, pH 7522, PaCO2 48 mmHg, HCO 38 mmHg, serum potassium 29, chloride 88. Urine chloride is low. Read the command, the disturbance and why it persists. Recurrent vomiting, high pH, high bicarbonate, hypokalemia, low chloride, low urine chloride, metabolic alkalosis from vomiting. The primary disturbance is a metabolic alkalosis, pH 7.2 with a high bicarbonate of 38. The rising PaCO2 of 48 is appropriate respiratory compensation, hypoventilation to retain CO2. The cause is vomiting. Each milliliter of vomitus loses hydrochloric acid from the stomach, so the body loses hydrochloric acid from the stomach, and bicarbonate rises. But the interesting part of the question is why it persists. 2 factors maintain it. First, volume contraction. The kidney avidly reabsorbs sodium and, with it, bicarbonate, and the low chloride limits bicarbonate excretion. Second, hypokalemia drives H+ into cells and increases renal H+ secretion, regenerating bicarbonate. The correct answer is E. This is a chloride-responsive or saline, responsive metabolic alkalosis. The low urine chloride confirms it, and it corrects with saline and potassium repletion, which restore volume, chloride, and potassium, so the kidney can finally excrete the excess bicarbonate. The mechanism of persistence, contraction plus hypokalemia, is the high-yield teaching point. Which gene is most likely mutated? A 45-year-old woman with a strong family history of breast and ovarian cancer, mother and sister, both premenopausal, presents with a firm, irregular, fixed breast mass. Biopsy shows invasive ductal carcinoma. Genetic testing reveals a germline mutation in a gene encoding a protein involved in repairing double-strand DNA breaks by homologous recombination. Read the command, which gene? Premenopausal breast and ovarian cancer, strong family history, double-strand break repair by homologous recombination, BRCA1. The gene is BRCA1 on chromosome 17. BRCA1 and BRCA2 encode tumor suppressor proteins that repair double-strand DNA breaks through homologous recombination, high-fidelity repair. When one inherited copy is mutated and a second is lost, cells accumulate DNA damage and become malignant. Carriers have a markedly elevated lifetime risk of breast cancer and, distinctively, ovarian cancer. The combination of breast plus ovarian cancer in a family, especially premenopausal, is the signature. BRCA mutations follow autosomal dominant inheritance with the classic two-hit tumor suppressor mechanism. The correct answer is A. The functional description, repairing double-strand breaks by homologous recombination, is the specific fingerprint of BRCA. This also explains why BRCA-mutated tumors are sensitive to PARP inhibitors, which block the backup repair pathway and cause synthetic lethality. The other genes cause different syndromes: RB1, retinoblastoma; APC, familial colon cancer; RET, MEN2, TP53 leaf ramini. What is the mechanism of hepatotoxicity and the antidote? A 19-year-old woman is brought to the ED 16 hours after intentionally ingesting a large quantity of acetaminophen. She now has nausea, vomiting, and right upper quadrant pain. Labs show rising AST and ALT and a prolonged INR. Read the command mechanism of hepatotoxicity and antidote. Acetaminophen overdose with hepatotoxicity. Toxic metabolite. NAPQI depleting glutathione treated with N-acetylcysteine. At normal doses, most acetaminophen is conjugated safely, and a small fraction is oxidized by cytochrome P450 to a toxic, highly reactive metabolite called NAPQI, N-acetyl-P benzoquinone imine. NAPQI is normally neutralized by conjugation with glutathione. In overdose, the conjugation pathways are saturated, more drug is shunted to NAPQI, and glutathione stores are depleted. Unquenched NAPQI then binds and damages hepatocyte proteins, causing centrilobular hepatic necrosis, explaining the rising transaminases, the prolonged INR from lost synthetic function, and the RUQ pain. The correct answer is C. The antidote is N-acetylcysteine, which works by replenishing glutathione and providing sulfhydryl groups, so the body can detoxify NAPQI. NAC is most effective when given early, guided by the acetaminophen level on the Roux-Matthew nomogram, but is still given late in established toxicity. Match the toxin, fomepizole for methanol ethylene glycol, deferoxamine for iron, but for acetaminophen it is NAC. Which feature of this organism's cell wall is responsible for the acid-fast staining and its resistance to killing? A 44-year-old man with HIV CD4 count 180 presence with 6 weeks of cough, low-grade fever, night sweats, and weight loss. Chest x-ray shows a right upper lobe cavitary infiltrate. Sputum acid-fast staining is positive. Biopsy of a hilar node shows granulomas with central caseous necrosis. Read the command, which cell wall feature explains acid fastness and resistance? Cough, weight loss, night sweats, upper lobe cavitary lesion, acid-fast bacilli, caseating granulomas. Mycobacterium tuberculosis. Mycobacterium tuberculosis owes its defining properties to mycolic acids, long-chain fatty acids that form a thick, waxy hydrophobic layer in the cell wall. This mycolic acid coat is what makes the organism ACIZ fast. It resists decolorization by acid alcohol after carbofuchsin staining, the basis of the Zeal-Nielsen stain. The same waxy wall makes the bacterium resistant to many disinfectants, antibiotics, and to killing by macrophages, allowing it to survive intracellularly and persist. TB also inhibits phagolysosome fusion, surviving inside macrophages and driving the caseating granuloma. The correct answer is B. The granuloma with central caseous cheese-like necrosis is the histologic hallmark of TB, distinguishing it from the non-caseating granulomas of sarcoidosis. The reactivation pattern, upper lobe cavitation, reflects the high oxygen tension TB favors. Mycolic acids are the specific cell wall component behind both the acid-fast stain and the organism's durability. What is the underlying deficiency? A 24-year-old woman presents with recurrent episodes of self-limited, non-pitting swelling of the face, lips, and hands, and occasional abdominal pain from bowel wall edema. The episodes are not associated with urticaria or itching. there is a family history of similar attacks. Complement studies show low C4, ACE inhibitors trigger severe attacks. Read the command. Underlying deficiency. Recurrent angioedema. Without urticaria or itching. Family history. Low C4. Worse with ACE inhibitors. Hereditary angioedema. C1 esterase inhibitor deficiency. Hereditary angioedema is caused by a deficiency of C1 esterase inhibitor. This inhibitor normally restrains two systems, the complement cascade and the kallikrein-bradykinin pathway. Without it, bradykinin is overproduced, and bradykinin is a potent vasodilator that increases vascular permeability, causing the recurrent, non-pitting angioedema of the face, airway, and bowel wall. Crucially, this is a bradykinin-mediated process, not histamine, which is why there is no urticaria and no itching, and why antihistamines do not help. Chronic consumption of complement lowers C4, the screening clue. The correct answer is D. The ACE inhibitor association seals it. ACE normally degrades bradykinin, so an ACE inhibitor raises bradykinin further and triggers severe attacks. These drugs are contraindicated. The absence of hives and itch separates this bradykinin-mediated angioedema from the histamine, IgE-mediated allergic angioedema of choice. Low C4 with a positive family history points to C1 esterase inhibitor deficiency. Block 6 is done. Let's review the 5 biggest traps from this block. Trap 1. The erythropoietin level splits the polycythemias. In polycythemia vera, JAK2 drives autonomous production, so EPO is low by feedback. In secondary polycythemia, high EPO is the cause. Low EPO points to the primary marrow disease. Trap 2. Brown, Saquard. Pain and temperature loss is on the opposite side of the lesion because the spinothalamic tract crosses immediately at the cord. Vibration, proprioception, and motor loss are on the same side because those tracts cross higher up. Trap 3. Homocystinuria versus Marfan. Both are tall and marfanoid with lens dislocation. Homocystinuria dislocates the lens downward and adds thrombosis and intellectual disability, often B6 responsive. Marfan dislocates upward. Trap 4. Statistics. A confidence interval that crosses 0 and a p-value above 0.5 mean the result is not statistically significant, but that is not the same as proving no effect. The study may simply lack power. Trap 5. Hereditary angioedema. The swelling is bradykinin mediated, so there is no urticaria and no itching, and antihistamines fail. It is C1 esterase inhibitor deficiency, and ACE inhibitors make it dramatically worse. Train process, not memorization. 6 blocks complete, your timing and pattern recognition are sharper every set. StepLogic, learn how to think, not memorize.